Welcome to a very special masterclass edition of The Explainer. Today we're simulating a high-stakes consultant-level general surgery viva exam. You know, the kind that really puts you to the test. We're going to be focusing on some really complex trauma scenarios.
So here's what we've got on tap. We'll start with the exam setup, then dive into our first case, a splenic injury. We'll look at some challenges that can pop up, then move to a second case focusing on damage control. After that, a quick look at penetrating neck trauma, and we'll finish up with the most important, high-yield takeaways for any exam. Let's get started.
All right, so for this, I'll be playing the role of the examiner, and we have our candidate ready. Let's jump right into the first case.
Okay, candidate, let's begin. You have a 23-year-old male who's just been brought into the emergency department after a road traffic accident. He's lethargic, his blood pressure is way down at 87/56, and his pulse is racing at 132. To top it off, his fast scan is positive. So you're faced with this patient. How are you going to approach this situation? The floor is yours.
Thank you. Okay, in this scenario, my first priority is to follow the Advanced Trauma Life Support Protocol, the ATLS protocol. It has to be systematic.
So I'm going to run through my primary survey. First, airway. The patient is talking, so his airway is clear, but I'm maintaining C-spine protection, of course. Next, breathing. I'll give him high-flow oxygen, check his chest, air entry is equal, which is good. Then circulation. This is where the real problem is. I'm immediately getting 2 large-bore IVs in, drawing bloods, and starting aggressive fluid and blood resuscitation. I'm also looking for any external bleed to control. For disability, his GCS is 14 out of 15, so he's a little confused, and his pupils are fine. And finally, exposure. We need to get him fully undressed, log roll him to check his back, and then cover him right back up to prevent hypothermia. So putting it all together, my primary survey is screaming hemodynamic instability with a positive fast scan. This tells me he's got intra-abdominal hemorrhage.
Okay, let's stop right there. You're doing all the right things. You're pouring in fluids, you're giving blood products, but it's not working. The patient is not responding. He's still in shock.
So what's the game plan now? What is your definitive next step?
Well, given that he's still unstable and we have strong evidence of internal bleeding, there's only one answer. The definitive next step is an emergency exploratory laparotomy. We have to go to the operating room now.
Okay, so my plan is this. First, I'm immediately alerting the operating room, the anesthesia team, and the blood bank. We need all hands on deck. Once in the OR, I'm making a big midline incision from xiphoid to pubis. As soon as we're in, there's going to be a lot of blood. The first move is to get all that blood and clot out, and then immediately pack all 4 quadrants of the abdomen. This is crucial because, when you open the belly, you release that tamponade effect, and the blood pressure can just plummet. So we pack, and then we tell the anesthetist, okay, catch up. We give them time to pour in more blood and fluids. Only when the patient is a bit more stable do we start systematically removing 1 pack at a time to find out where the bleeding is coming from.
Okay, you remove the packs and you find the source. It's a grade 5 splenic rupture. You've looked everywhere else and there are no other injuries. What's the surgical intervention?
For a hemodynamically unstable patient with a shattered spleen, the definitive procedure is an emergency splenectomy. I'm going to proceed with that right away, and once the spleen is out, I'll place an intra-abdominal drain.
All right, the surgery goes well, but a few days later, you notice the drain is still putting out a lot of fluid. You send a sample to the lab, and the fluid amylase comes back sky high, much higher than the serum level. You've diagnosed a pancreatic fistula. How are you going to manage this?
Okay, so for a pancreatic fistula, management is mainly conservative. The goal is to let the pancreas rest. So first step, make the patient NPO, nothing by mouth. This reduces pancreatic stimulation. Of course, they still need nutrition, so we'll start IV fluids and TPN to maintain their hydration and give them calories. We can also use a drug called octreotide, which helps decrease pancreatic secretions. And we have to be really careful with wound care to prevent the skin from breaking down from all those enzymes. Now, most of these will close on their own, but if it persists, we can go for an ERCP, maybe place a stent to help it drain internally.
Excellent. And of course, we can't forget the final management point for this patient, post-splenectomy vaccinations. That's an absolutely critical safety step. But let's throw a wrench in the works. Let's rewind. Intraoperatively, as you're trying to get control of that spleen, the patient becomes severely acidotic and hypothermic. What do you do?
Okay, that scenario changes everything. The patient is developing the lethal triad. In that case, I'm abandoning the idea of a definitive repair. My entire strategy pivots to damage control surgery.
Exactly right. And this slide really nails the difference. It is a completely different mindset. With definitive surgery, your goal is a perfect anatomical repair. But with damage control, you're not trying to be a hero in the OR. Your goal is simply to stop the bleeding, control any contamination, and get out of there fast. The real life-saving work happens in the ICU, correcting their physiology. So let's move to a new case where damage control is the plan from the very beginning.
All right, new patient, 33-year-old woman, another bad car crash. Her pressure is in her boots at 69/46. Her temp is dropping. The fast is positive. You've taken her straight to the operating room.
Okay, so we open her up and we find a deep, nasty liver laceration. Every time we try to remove the packs to see what's going on, it just gushes blood. This patient is a classic, textbook candidate for damage control surgery right from the get-go.
So my definitive action is to not attempt a definitive repair. The plan is simple. Control the bleeding by packing the liver again nice and tight. We're not attempting any complex suturing. Then control contamination. If there was a bowel injury, we just staple it off. And then we do a temporary closure of the abdomen. The whole point is to get her to the ICU as fast as possible so she can be warmed up and her acidosis and coagulopathy can be corrected. We'll plan to bring her back to the OR for a second look in about 24 to 48 hours when she's more stable. The goal here is physiological restoration, not anatomical perfection.
Very good. Okay, let's shift gears completely now. I want to test your breadth of knowledge. A patient arrives in the ED with a penetrating neck injury, let's say a stab wound to the side of the neck. Outline your initial approach for me.
Okay, for penetrating neck trauma, the very first priority is the airway. You have to secure the airway. Then control any active bleeding with direct pressure. After that, everything really depends on one thing. Is the patient stable or unstable? And do they have any hard signs of a major injury? We're talking about things like an expanding hematoma, shock, or air bubbling from the wound. If they have any of those hard signs, they are going straight to the operating room, no delay. But if the patient is stable, then we have time for diagnostics. The workhorse here is a CT angiogram of the neck. That will show us any vascular or other injuries and help us decide if they need an operation or if they can be managed non-operatively.
Very good. Okay, let's bring it all together. What are the most important high-yield principles we've covered today?
Okay, so looking at this list, these 5 points are really the heart of managing complex trauma. First, you have to follow the ATLS protocol every single time without deviation. It's your safety net. Second, the decision to do an emergency laparotomy isn't based on a CT scan. It's a clinical decision based on the patient being unstable. Third, you absolutely must know the triggers for damage control surgery, that lethal triad of acidosis, hypothermia, and coagulopathy. Fourth, you've got to be a master of post-op complications like that pancreatic fistula we discussed. And finally, never ever forget the follow-up details like post-splenectomy vaccinations. That's a huge patient safety issue. Honestly, if you master these 5 concepts, you've mastered the core of trauma surgery decision-making.
And that concludes our Viva, so I'll leave you with one final question to think about. We live in an era of incredible technology, advanced imaging, amazing interventional radiology techniques, but what's the single most important skill a trauma surgeon still needs to have in the operating room? Something to ponder. Thank you for joining this masterclass from The Explainer.